So we're back with Nadia's crew. Nadia's Monday morning started the way every Monday started, in the hallway, between the supply closet and the exam room, having a conversation that should have happened before the first patient arrived, but didn't, because there was no time, there was no structure, no habit of making it happen. The charge nurse grabbed her at 8:12. Two medical assistants had called in sick. The afternoon physician was running 30 minutes behind before the day had started because a procedure from Friday had generated paperwork that nobody finished. The lab interface, the same one that failed twice in the past 4 months, was showing an error message that Felix hadn't seen yet because Felix started at 8:30. Nadia handled all of it. She covered the front desk for 20 minutes. She called the staffing agency. She walked Friday paperwork to physicians personally. She texted Felix a screenshot of the error. By 9 a.m., the fires were out. By 9:15, two new ones had started. The thing about Nadia is that she's brilliant at this. The hallway triage, the real-time problem solving, the human routing engine that keeps the clinic from collapsing every morning. She's so good that nobody notices the cost, which is that Nadia never actually gets to do her actual job until after lunch, because every morning is consumed by problems that ambush her one at a time in random order with no warning and no pattern, except there was a pattern. Nadia just could not see it because she was inside it. The staffing gaps that surprised her on Monday had been visible on Friday. Two MAs had flagged availability issues in the scheduling system, but nobody reviewed the next week's roster before the weekend. The physician's unfinished paperwork had been sitting since Thursday, but nobody tracked open documentation as a daily metric. The lab interface error had been intermittent for a week, but nobody escalated it because there was no forum for escalation, just hallway conversations that evaporated the moment someone got pulled to the next task. Every one of those Monday's crises was predictable. Everyone was preventable, not with more staff, not with better technology, but with 10 minutes. That's the argument. And it sounds too simple to be true. A 10-minute meeting, standing every morning before the first patient, right? The daily huddle. Nadia had heard of it. She'd read about it in a management article. She'd bookmarked, but never revisited. She'd file it in the same mental category as most operational advice, theoretically sound, practically impossible. Because the most common objection is always the same. We don't have 10 minutes. The honest answer, the one Nadia would not discover for another 3 weeks, is that clinics that don't huddle spend far more than 10 minutes per day in exactly the same chaos that she was already joining in. The hallway conversations, the emergency escalations, the text messages at 8:12 a.m., the rework from problems that could have been named at 7:50 and solved by 8 a.m. She didn't have 10 minutes to spare. She was spending 40 minutes on the consequences of not having those 10 minutes. The shift happened because of a Thursday, not a catastrophe, a quiet, exhausting Thursday where three things went wrong simultaneously. None of them enough to qualify as a crisis, all of them disruptive enough to derail the afternoon. A patient with complex needs arrived without the necessary imaging. A supply order had been placed but not confirmed, leaving one exam room without basic materials. And a safety concern from the morning, a near-miss medication error went unreported until shift change because nobody felt they had the right forum to raise it. Nadia stayed until 7 p.m. that night, not because the work was hard, but because the work was invisible until it exploded. She started the huddle the following Monday, 7:50 a.m., 10 minutes, standing in the hallway outside the break room because the conference room was booked, and Nadia had learned that waiting for the perfect conditions was the same as waiting forever. The first huddle was awkward. 4 people showed up: Nadia, the charge nurse, and Maureen, who attended with the energy of someone fulfilling a court-ordered obligation. Nadia ran through the agenda she'd written on an index card, 5 items: safety and quality alerts from the past 24 hours, capacity checks, staffing gaps, equipment, room availability, priority patients, high risk, delayed, or anyone requiring special coordination, active blockers, anything preventing smooth operations that morning, and the decision ownership, who was responsible for resolving each blocker by name and by when. The first huddle took 14 minutes. 3 of those minutes were Maureen explaining that the supply closet inventory was wrong and had been wrong since September. Nadia wrote it down and assigned it, named a resolution lead and a deadline. That's been a problem for 4 months, Maureen said. Nobody asked me about it until now. Nobody had a place to ask, Nadia said. The second huddle took 11 minutes. The third took 9. By the end of the week, something shifted. Not dramatically, not visibly, but in the texture of the mornings. Nadia's phone buzzed less, not because problems disappeared, because problems were surfaced at 7:50 instead of ambushing her at 8:12. The staffing gap that would have been a Monday morning scramble got flagged on Friday's huddle. Dr. Mina attended the huddle on the second week. He stood in the back. He didn't speak. He watched the charge nurse report a near miss from the previous afternoon, a medication dosage that had been caught by a second check, but that should not have needed catching. In the old system, that near miss would have been mentioned to Maureen in the hallway, possibly documented, possibly, and probably forgotten. In the huddle, it was named, discussed, and assigned a root cause review in 90 seconds. Dr. Mina pulled Nadia aside afterwards. How long has this been happening? The near misses. They've always been happening, Nadia said. We just did not have a place to hear about them. The huddle is not a status update. It's a decision-making ritual. The difference matters because status updates inform, decisions protect. By week 3, Maureen was running the safety segment of the huddle, not because Nadia asked her to, but because Maureen recognized that the huddle was the first operational habit in 14 years that actually wanted to hear what she knew. She brought her own list, detailed, organized by severity. She delivered it in under 2 minutes with the precision of somebody who had been waiting a very long time to be asked. Doris started attending in week 2. She brought the patient-facing intelligence nobody else had. Which insurance companies were rejecting claims that week? Which patients had filed complaints overnight? Which referring physicians had sent incomplete referrals? Information that lived in the front desk and never traveled further than Doris's memory until now. They redesigned the intake form without asking me, Doris had said once, about a different problem. This time, nobody redesigned anything without asking. The huddle was the asking. By week 4, the huddle had done something that no training program, no software, no motivational poster had managed in 3 years. It had changed the default from reactive to anticipatory. The team stopped managing by crisis and actually started managing, right? Not perfectly, not every day, but enough to know the difference was felt in the hallways, at the front desk, in Nadia's phone, which had gone from 14 buzzes per hour to 8. The evidence backs it up. High fidelity huddles, held on 75% or more of working days, measurably reduce excess length of stay and clinical alarm rates. They improve problem identification, situation awareness, teamwork, and cross-department collaboration, not because the huddle itself is magical, but because the huddle creates a container for attention. And attention directed consistently at the right things changes what happens next. Huddle discipline is a leading indicator of operational health. If a team cannot maintain a 10-minute daily habit, it's a signal that ownership, scheduling, or accountability structures need attention. The huddle doesn't just fix problems, it reviews the organization's capacity to fix problems. That's why it goes in week one of any operational rebuild. It's the foundation on which every other improvement gets built. Nadia still arrives early. She still checks her phone at 11 p.m. sometimes, though less often now. The difference is the mornings. At 7:50, four people stand in a hallway and spend 10 minutes naming what's coming, deciding who owns it, and moving on. It's not dramatic, it's not inspiring, it's small, boring, extraordinarily effective habit that replaced 40 minutes of chaos with 10 minutes of clarity. Nadia left the clinic at 5 p.m. on a Friday, not the first time, but one of the first times she left without feeling that something was about to break behind her. She didn't check her phone until Saturday morning. If your clinic or your hospital manages by hallway conversations and Monday morning surprise, the fix isn't a new system. It's a 10-minute standing before the first patient every day. That's it. That's the meeting.